So first of all, thank you very much for the Tamil Nadu State branch of IIP for inviting me for their annual conference. The topic which I'm given is practical approach to remote consultations for pediatric patients during pandemic. This was a case which I got on 24th of March 2020. I mean, in fact, the COVID lockdown started on 24th of March, and 26th I got call. My reception is asking whether I can give a teleconsult for a 3-year boy running fever for 3 days. Obviously, the question came to my mind: is it legal to give the teleconsult? How do I do it? What's the logistic? How can I optimize it? And does it carry legal responsibility? So these are the questions come to every pediatrician who goes through this kind of a sequence of events. Now let's take one by one these questions, which will give you the practical answers to it. So is it legal? In fact, most of our senior consultants who are super consultants, super specialty consultants, they have been doing it the distant consulting for years behind or years in the back, which perhaps was not legalized. COVID lockdown has just made it essential legally. So it was there, but it's kind of a hastened, and perhaps COVID lockdown remaining, had it remained for a week or two, perhaps the thing won't have been that effective. But since it lasted for almost now 1.5 years, it has become a part and parcel. So now even if the lockdown and everything restriction goes off, this is going to be the kind of a lifestyle for us. There is no new legislation to regulate this teleconsult. In fact, there was a MCI guideline which was released on 25th of March. So 24th of March was the lockdown. 25th of March 2020, this guideline came into picture. And this was based on the pre-existing jurisdictions of FDA, the information technology, and the medical laws. The guidelines are the practice norms to be followed by the RMPs. So that was governed by, I'll tell you what exactly the RMP means. And these are the guidelines which are available on the MCI website, the telemedicine practice guidelines, and whole talk will be reasonably based on these basic guidelines. So certain terminology we need to be understood here: the telehealth, the telemedicine, and what is an RMP. Now, telehealth is nothing but all the acts which are under healthcare and health education related. So everything, the health teaching, the kind of a basic health counselings, the routine day-to-day care, the kind of a teaching part that we do. We are at present on a webinar, we are on the conference. This is all part of telehealth, anything related to health, not essentially prescription, clinical medicine. It's kind of a big terminology under which telemedicine is just one part of it, which means it is more of a giving direct consultation to the patient and prescribing the medicine wherever available, wherever possible, or healthcare counseling given. So telemedicine is just one part of telehealth, which is a broader umbrella. A registered medical practitioner or RMP is the registered, he is a person who is enrolled in the state medical register or the Indian medical register under the Indian Medical Council 1956. So every registered practitioner is governed by this kind of a guideline. What are the possible consultation that we will be doing on a teleconsult? It could be patient to the RMP directly. It could be caregiver of the patient to the RMP, wherein the authorization of caregiver from the patient is must. Health worker to the RMP, or it can be RMP to RMP, some kind of a general practitioner calling a consultant in the town place or a super consultant in a town place. That is also possible here. In all communications, identity of patient and RMP to each other is very mandatory. And when a RMP is talking to RMP, a senior consultant, and then that referring person is going to execute the action, execute the treatment, he is essentially responsible for the treatment. What are steps in teleconsult? Steps are basically, we need to have a platform to consult. We need to identify the patient and the RMP. We need to take a consent from the patient. I'll tell you what kind of consents can be taken. We need to decide the suitability of consent. So whether this particular patient is suitable to be treated on teleconsult or he has to cover a physical consultation. And finally, deliver consult if it is suitable. Now, what platforms are available? There are almost 10 good platforms available in the Indian scenario, which are as per the MCI guidelines, and they will be following this advantage, the kind of a secrecy part of it, storing of this data and not to share with anything, remain the liability of these authorized platforms. So they are well versed with this present kind of situation and giving the telemedicine. Consult can be audio, audio visual, or text messages. They have their own advantages and disadvantages. When we are talking about audio visual, obviously it requires a good internet access, which is still a shortcoming in distant peripheries. They have a better confirmation of identity when it comes to audio visual. Possibility of more visual clinical clues. So if you need to see some skin lesion, you need to see some masses, that can be better done with the visuality. Real-time consult, whether it is audio or audio visual, there's a real-time direct face-to-face, direct kind of a talk between the patient and the RMP. And sending prescriptions by photograph messages again is possible with audio visual kind of a device. Recording of consult, which is possible with audio visual as well as by text messages. So all of them have their own advantages and disadvantages. Perhaps best suited will be the audio visual kind of a platform where everything is possible, but being the limitation of having a good bandwidth to your internet services. Patient identity and consent. It is essential to confirm and document patient identity to RMP and RMP's identity to the patient before we start the consultation. The patient must know whom he is talking to and whom he is taking the consultation from. Known patient to on follow-up. So if it is a follow-up patient, then perhaps these norms can be a bit relaxed once the RMP confirm that's the same patient. Implied consent. When the patient takes an appointment, it is considered that patient has already consented to the treatment given the patient, and you don't have to take a separate kind of a consent. But there could be explicit consent. After the consent, next day the RMP wants to inform something to the patient. Now here there is no implied consent, so we need to have a separate written consent on message or on the email before we give the consultation to the patient. So these two kind of consents are kind of involved in this. Criticality. So once you start, you have identified the patient, you have taken the consent. The next step is to determine whether the patient is critical. So first medical step in your consult to determine whether the patient is critical, which is possible by taking few immediate kind of a complaint history. They will make you understand. If it is audio visual, then still better, wherein at least the basic understanding of airway, breathing, circulation and disability as per the IAP ALS guidelines. You can determine whether this is a very sick patient who may not be able, you may not be kind of giving consultation online. If there is a video consult, then you can easily recognize by PAT, the pediatric advanced triangle, this things assessment triangle, wherein it's a consciousness, breathing and circulation, which can be assessed on video within 30 seconds. That's what we do in your clinic also, look, listen, feel without touching the patient within 30 seconds. So with this, if the complaints are significant, patient sounds to be critical, then recommend first aid and advise to rush to the nearby emergency room. Simple case, a 6-year boy fell down from second floor, unresponsive for 1 minute immediately, has left ear bleed and neck pain now. He is lethargic now. He can be given tele-consult. Can he be given tele-consult and management at this point of time? You get a phone call from the father, what do I do? So is it safe to give it? Can you give the first aid to this patient? Health education advice? Yes, all these things can be given, but patient has to be rushed to the emergency care. What kind of first aid can be given or education, health education? You tell them as far as possible not to move the neck or spine. There could be a spinal injury which can push the child into quadriplegia. So some kind of if the feel the patient is educated enough, he may be shown this photograph, and first while putting this, he should be told not to move the neck at all. 2 or 3 people have to assist in doing this, and this can ensure that there is no further damage. Mind you, all these things are risky procedures. Of this has to be explained, and most important, this patient need to be immediately taken to the emergency room. That is to be kind of pushed on that consultation. 8-year girl, known patient of asthma, mother calls for acute aggravation of an attack. Your consultation ask and look for the red flag sign. So when he comes distress, you will be looking for essentially how is the sensorium of the child, is lethargic, responded to your verbal commands, the work of breathing, how severe is the distress, can she talk a full sentence? Perhaps this one can tell you. If she can't make a sentence, then yes, probably it's a severe asthma. If there are no red flag signs, so if he's having any of them, patient has to the emergency room. While on the way, he can be advised to give this MDI salbutamol 100 6 puffs in next 20 minutes and can be repeated 3 times in next about 1 hour. So 18 puffs can be given, and If he's at home, no red flag sign, and child shows improvement, further thing can be carried out at home with a further consult. But if there is no improvement, certainly the patient has to rush to the ER. This much of an advice really makes a lot of difference, because more than 50% of your patient will be able to manage the patient at home. Another case, call from your known village person 150 kilometers away for a snake bite to a neighbor's 4-year-old daughter. Can you give a consult to this? Ethical advice. You need to advise him to take it to the nearby RNP and call SOS once the RNP examines the patient. You get a call after 1 hour. Child is sleepy, not opening the eyes completely. You don't have ICU ventilation facility. You inquire whether he has a ventilation facility. Don't. Then obviously this child has to be shifted to place where it is available. If it's far away, then better give a ASV dose and intubate this patient and transfer. This is very valid advice, very important advice. This patient is shifted to this 150 kilometers away on the road, may take another 3-4 hours, and the patient may die on the road. So that is the validity, that is the importance of a teleconsult. Is it suitable for a teleconsult? The next question, you rule out the criticality, then decide whether it is suitable. So certain age group, less than 3 months baby, there is limitation to the clinical examination, even in your consulting physical. On the online consult, perhaps that will be not at all safe to consult a baby less than 3 months. This baby should be seen physically. New unknown patient, you need to be careful. There is any doubt, call him for a physical examination. If the history is not clear or suspicious, if there is inadequate clinical information available, diagnosis not possible without clinical examination, definitely you need to call this patient for a physical consult. A 3-year-old boy, your old patient, he complains of fever for 4 days, moderate to high grade, some dysuria, polyuria, history of constipation. I think the history is clearly looking like a UTI. Your consultation is possible, suitable here. You advise him to do urine routine microscopic and culture, give him paracetamol and report back after the primary reports are available. So that can be done. This is doable and you can give that. But this is another patient, 8-year boy, new patient, fever for 15 days, seen by local GP for last 3 visits. Detailed history shows almost same pattern of fever over 15 days, mild cough and some rashes. Now this can be anything. This can be connective tissue, this can be malignancy, this can be any infection, low-grade infection, very difficult to make anything. Can you advise? Can any investigation? Can you treat online? Perhaps not. There are limitations to the consult when there is a new patient, non-localized indices, multiple differential diagnosis, and you cannot guide them without examination. So this patient has to come for a physical consult. Another case, 2-year-old, your old patient was on tour to Goa, had breathlessness, so admit locally. Father want you to opine online. How to go about it? You can take some brief history, call the treating doctor. That's the best way, because he's seeing the patient physically. Discuss and take his opinion into consideration. Give him your feedback based on your previous experiences with this patient, and a final decision to be taken by treating doctor. He is in a better position to this patient, and also the vicarious responsibility goes to the treating doctor. When somebody RMP is already involved, try and involve him, try to put the responsibility onto him. That is much safer. What can be offered on teleconsult? Health education like advice on nutrition, hygiene, immunization advices can be given. You can counsel the patient on various grounds as far as disease, as far as the prognosis, as far as the future precautions, all can be told to them. Medications, yes, there are certain groups which can be given, certain which cannot be given. So which medicine can be prescribed? There is a list O drugs which are OTC product, paracetamol, cough lozenges, iron, folic acid, vitamin D. Government notified drugs in endemic zones of malaria, chloroquine can be given online. So there are groups. First, medications after video. All medications added. No, they also can be given with a clear red flags informed to the patient. Certain drugs, the list B drugs, add-on drugs in follow-up conditions, monitoring of such drugs. Now this list is given on the MCI website. You can go through that. What is specific about the prescription paper? It is same as your routine OPD paper. The name, identity, notes, medications, if possible, address, phone number, everything has to be there. One important caveat in the block letter, it is teleconsult and patient is not examined physically, though that gets a clear message to the medico-legal law as well. Mention expected red flags So once you relevant to the case, as I said in the asthma patient, mention the red flags. The child becomes unconscious, drowsy, lethargic, then has to rush to the emergency room. One copy of the prescription, physical or digital, to be retained by the RMP. What are the advantages practically at the end of this? You are saving a lot of time, traveling, money for the patient. You are working from home. Mind you, we never did that in the past. And now this is a new era where you can continue to work even after your physical retirement. You can work from anywhere. You're going to a conference in US. You can keep 2 hours for a teleconsultation at your convenience. Then you can talk to your patients. For both flexibility of time, emergency first aid advice. Yes, those patients staying far away or maybe even closer to you, you can give certain advice till the time patient reaches your emergency room. Mandatory in crisis situation like lockdowns. So in case of COVID, perhaps this is one, all the senior consultants were online available, and that saved so many patients. Preventing OPD congestion, very important. Your small OPD room now perhaps can be closed down. You can keep a smaller waiting rooms and do your consultations online. You can reduce half the workload there. Prevention of cross infection. Many of your newborn, the infants, the parents are worried. The educated parent asks you, sir, how can I come? He sits outside in the car till the night time the number comes, appointment comes. So that can be reduced automatically here. And super specialty consult, one of the most important. You are sitting 100 kilometers away from the metropolis, no neurologist available, pediatric neurologist available. You can take an appointment. Rheumatologist, you can take an appointment. You can inform all the findings. He will guide you what to do next, and perhaps he is safe, you are safe. What need to improve? What are the limitations of clinical examination to be overcome by detailed history? One most important thing in a teleconsult is you can see what need to improve here. What we do in any consult, we take a good history, we do examination, we investigate, we diagnose, and then we treat, and then we maintain the medical record. The whole thing remains the same, perhaps with one little change, that the part of the examination remains to be limited and that the brand goes on to a good detailed history. So that's kind of a thing which has good detailed history, where my teacher Dr. Ambedkar used to focus 80% time on history taking and 20% on clinical examination. This is what perhaps we have been doing for years, and that's how those who are doing it, they will find the teleconsult much easy and convenient. And not to forget, keeping good medical record. So responsibility of a RMP who is doing teleconsult, medical ethics have to be followed more stringently. Privacy policy, I'm sure these things we always follow as it is in practice. Data confidentiality, to a great extent, the responsibility lies on the tele platform that you're using by the law. So I'm sure you're not sharing the data, but they are also not supposed to share the data. If there is any leakage, they are also equally responsible for this. Maintain all records, audio, video, and patient information and prescriptions. Very important. Fee structuring appropriate to consult. There are various rules. Less than 6 months is the first consult. After 6 months, it's going to be second. Again, the review consult or new consult. If the patient comes with a new symptom within 6 months, again new consult. You can follow. I suppose these are more like our personal ways. Everybody has his own structuring. Though this is what is given in the guidelines. Receipt record need to be maintained, and there are certain flow charts. If the time is less, I may skip it. This is available on the MCI website. Just quickly, first consult patient, decide which platform you want to use, video, audio, text. You identify the patient, take the consent, quickly assess whether he requires emergency care. If yes, he has to be guided to the emergency room and give the primary first aid on way. If he is not in emergency care, then go through the detailed history and kind of a clinical examination, decide whether he's suitable for the consult. If he's not suitable for the consult, give him health education counseling and call him for the physical examination. If he's suitable, then you can give the management in the form of health education, counseling, and a specific treatment as per the list O drug. In case the teleconsultation is on video, prescribe medicines in the list A drug. So audio, video, you can give list A drug as well. It's very simple kind of algorithm. When the patient comes for the follow-up consult, the initial part remains the same, but when it comes to follow-up consult, something will change on the follow-up consult. If he has got a new complaint, then it comes like a first consultation. Once again, the rest of the algorithm for a follow-up consult remain the same. If there is an audio-visual consult, you can use list A and list B drugs as well. If there is a health worker or attendant who is calling you for the help, again, the initial part of the algorithm remain the same. Identifying the patient, taking the consent, deciding which platform, decide whether there is any emergency need required. The emergency need required, obviously the patient has to come to the emergency care and give the primary counseling or kind of a first aid on the way to the emergency room. If that is not required, then again you are going for the detailed clinical history and examination, decide whether that kind of a consult is possible. The consult is possible, then you are on to this part. If it is not possible, patient is called again for the physical examination and detailed consultation. If it is possible to give, then you can give the same, follow the same. So it's very simple algorithm follow. Responsibility is a teleconsult. The vicarious responsibility of teleconsult is as much as physical consultation. You are responsible, obviously, within the limitations of telemedicine. Certain, like he has got a sliver which is 4 centimeter, which obviously I may not be able to palpate. He has got some oral inside mouth rash, you may not be able to see that. Child sensorium grossly you can judge. Child cannot move the limbs, perhaps you may not be able to move like that. So those limitations will be understood by the law as well. But yes, be careful when you are in doubt about such kind of findings, you should call the patient for physical examination. So responsibility is of the RNP who finally give services to the patient. So friends, to summarize, teleconsult is valid under MCI guidelines. It is most effective method of reaching the outreach in emergency or routine medical help. It is advantageous to patient and the RNP as well. Work from home has been introduced to us from this COVID era with the teleconsult. We need to improve our skills of history taking and evaluation to be more effective in teleconsultation. Thank you very much.
Thank you, sir.
Thank you very much. If there is any questions, I am happy to take
this type of topic is useful with the COVID lockdown, and it will be useful. I have one question.
Yes.
Is it legally necessary to record the audiovisual consultation?
It is always desirable. Every medical consult, it is desirable to record the teleconsultation. Desirable, I said. If you are on a audio platform, it's not possible. If you're on a text platform, it is not possible. And all these platforms are legally allowed. As
so
per
it is not mandatory.
It's not mandatory.
Okay. Any question?